If you were here last night, you know that the subject of our discussion today is two-tier healthcare in Canada. And why we are here is motivated in part by a court case that is happening in British Columbia, which builds on an earlier Supreme Court of Canada decision called Shauli from Quebec. I just want to be clear what we're talking about here to some extent. Shauli was, as you heard from Professor Martha Jackman last night, Shauli was a challenge to one specific law that a number of provinces have in order to try to protect public Medicare, and that is a law that bans private health insurance for covering medically necessary hospital and physician services. Not all provinces have this law, but a number do. As you know, that challenge was successful with at least on the grounds of the Quebec Charter. It was a split on the Canadian Charter. So the laws that prohibit private health insurance in other provinces still stand technically, and this matter has to be relitigated. This re-litigation is now underway in British Columbia. The challenge is being brought by Cambie Surgical Corporation, led by Dr. Brian Day. The challenge is a much broader challenge than it was in the Shauli decision. Partly, I think, as we'll hear from various folks today, the way that it worked out in Quebec was the ripping open of private markets or the flourishing of private markets did not actually ensue despite knocking that law down prohibiting private health insurance. And partly that was because of the response of the Quebec government at the time, but also because there are other laws that are in place that protect public Medicare. And those other laws are now being subject to challenge in the Cambie challenge underway in British Columbia. So in short, the challenge in British Columbia is a much broader based challenge going to the heart of protections of public Medicare. These include the laws that ban extra billing. So as you heard last night, if you were here, extra billing is where a physician is paid by the public system, but he or she then bills you in addition. So the idea of an extra billing is that you have to pay out. So perhaps they're paid $40 for seeing you. They may charge you another $40 by way of an extra billing. You experience that as a co-payment. You have to pay a co-payment for the service that you receive. Another law that's under challenge is laws that restrict or prohibit dual practice. So dual practice is where a physician works both for the public system and bills public Medicare and also can bill privately, either you as an individual or your private health insurance. And most provinces restrict dual practice so that a physician may practice privately but cannot as well bill public Medicare. And that diminishes the financial incentives for a large migration of physicians from the public to the private spheres. So that law too is under challenge. Various provinces also have laws that restrict pricing in the private sector. So a physician may opt out to practice privately, but in a number of laws, the prices that they can charge are pegged to what they can bill in the public sphere. And that too limits their financial incentive to want to opt out. So as you can see, there are a range of laws that exist in Canada. There are variations on these laws in all provinces. These laws are all under constitutional challenge in BC. Now, so if they are successful in whole or in part, the rest of the country, because we are talking about a challenge under the Charter of Rights and Freedoms, this will have an impact in all other provinces, unlike the challenge in Shauli, which ultimately was decided under the Quebec Charter and therefore only had legal impact in Quebec. So the stakes are very high. As many of you know, the litigation has been the on-again, off-again, longest litigation in history kind of thing. Maybe that's not completely accurate, but a very long process. It is recommencing on Monday, so we're right in the middle of it. I just want to bring that to your attention because there are people here who are involved in the litigation. There may be some of them that are speaking. So some of the questions that you may ask some people may not be able to answer them because of their involvement in the case. And I ask that you respect that and not throw tomatoes, depends where you come from, at them up here. Okay, so just be sensitive to that. I'm sure it's not that they don't want to answer your question, but they just might not be able to in the context of where the litigation is. So without further ado, we're going to launch into this and have a wide-ranging, broad discussion of the potential implications of this challenge. If they are successful, how should governments think across Canada about responding to any kind of court decision that may strike down one or more of these laws? This is my particular interest. How should governments respond? Because the court may do what it does, but that's not the end of the game. The governments can respond, and they will do if that happens, just as they did in Shiuli. So I think that's a very interesting question for policy people to start seriously considering if that should come to pass. So I'd like to welcome Gail Paech and the first panel to the podium. If you'd like to start coming up, Gail Paech is the president of Associated Medical Services, which has a long and interesting history apropos of private finance, and finances a lot of work around the history of the Canadian healthcare system and physician education. So thank you, Gail, for hosting this. And one of our panelists is on her way. Hi, voilà. Merci beaucoup.
Thanks very much, Colleen. And we'll just give you a second, Zeynep, to get organized. Oh, no, don't worry. Take care. Have a seat. Okay. All right, we have all of the panelists to kick off the day. And thanks very much, Colleen, and all of your colleagues, really, for organizing this conference. This really is extremely important that for our Canadian healthcare system, in that the opportunity to have this dialogue in such a timely fashion and really then start to think of that to look at and have the discussion about, so how do we respond if there are changes that are going to significantly impact the Canadian Medicare system in Canada. So today, the first panel that we are having are lessons from other countries on parallel private financing for Medicare. And this is really a key component. And so we have learned on many opportunities that if we look at other jurisdictions, we do have the ability then to learn lessons learned, to understand the outcomes and the impact that it has on its citizens. And so this is the first session that will occur this morning. And it gives me great pleasure to introduce the panelists who are presenting. And the first panelist on my immediate left is Fiona McDonald. And Fiona McDonald is a senior lecturer in the School of Law at Queensland University of Technology in Australia, and a member of the Australian Centre for Health Law Research. She is also an adjunct associate professor at the Department of Bioethics at Dalhousie University in Nova Scotia. Fiona's research encompasses governance of healthcare systems and institutions with a focus on rural health issues, governance of health technologies, and governance of health professionals. The second panelist that you will hear from is Stephen Thomas, and Stephen comes to us from Ireland, the Trinity College in Dublin. Stephen Thomas is director of the Centre for Health Policy and Management, Trinity College in Dublin. Prior to moving to Ireland, he was director of the Health Economics Unit at the University of Cape Town in South Africa, where he helped shape the post-apartheid health system and reform agenda. Steve's research areas is analysis of health system performance and reform. This draws on his experience of long-term international work in 4 different healthcare systems in high, middle, and low-income settings. The third presenter of the panel this morning is Zeynep Or. Zeynep is an economist and research director at the Institute for Research and Information in Health Economics in France. She has a PhD in economic analysis from Sorbonne University in Paris, and she specializes in evaluation of health system performance from an international comparative perspective, including the determinants of health outcomes, analysis of efficiency, equity, and health quality. And so you can see from the expertise of these individuals, they really do, and I'm sure will present in their presentations, the full scope and broad range of identifying what are the issues and how have these, from each of their own jurisdictions, addressed these issues. So with that, I would ask that Fiona come forward and be the first presenter. Thank you.
Whoops. Technology failure already. Okay. It's a great pleasure to be here. Yep. Right, it's a great pleasure to be here. Excellent. All right, and to contribute to this really interesting program, I'm really looking forward to learning a lot as the day progresses. I'd like to thank Colleen very much for the invitation to come here and to speak to you today, and to Giles and Deirdre and the others who assisted in organising this wonderful event. I'd also like to start by acknowledging the traditional owners of the land upon which I stand and their elders, past, present and emerging. So my brief today is to describe the Australian system, and I'm going to focus quite a lot on the political and constitutional structures.
Just need to move it closer to you.
Okay.
Yeah.
All right. So I'm going to focus today on the political and constitutional structures, excellent, that surround and have shaped the Australian approach to public-private finance in healthcare. So we did have a question yesterday about comparator countries when we're talking about this kind of thing. So here is Australia and here is Canada. Australia has 9.985 million square metres and Australia has 7.692 million square metres. Both countries have a population density of about 3.1 people. Canada's population is 35 million and Australia's is about 24 million. The population distributions are similar. An estimated 75% of Canadians live within 161 kilometres of the US border, and an 85% of Australians lives within 100 kilometres of the coast. So quite similar, and also have federal structures. Here are some of the key statistics in relation to various outcome measures. You'll see that Australia's GDP is slightly lower than Canada's. Per capita spending is lower, but there are significant differences in terms of wait times, etc., that show up in this data. All right, so now we're going to start with some history. Unlike Ireland, which Stephen is going to talk about, which reluctantly introduced private healthcare 30 odd years ago, Australia really reluctantly introduced public healthcare 34 years ago. Very, very reluctantly introduced it. At the foundation of the Commonwealth of Australia in 1901, the Commonwealth government had no powers in relation to healthcare. In 1944, it passed a Pharmaceutical Benefits Act to establish a pharmaceutical benefits scheme to provide subsidised pharmaceuticals for the population. That was all well and good, but the High Court of Australia, which is the equivalent of the Supreme Court of Canada, decreed that act null and void because the Commonwealth lacked the power to pass legislation in this sphere. So they convened a constitutional referendum that was successful, And it was agreed by the Australian public that the Commonwealth should have powers in respect of funding medical and dental services and hospital benefits. While the Australian population agreed to this idea enthusiastically, the medical profession was less than enamoured with the concept. They were very worried about the spectre of the National Health Service in England, and they were very worried about the possibility that they'd be required to work for government for a salary and that they would lose their lucrative public practice. Private practices, yes. So they were very concerned about that. So they lobbied very intensively with the assistance of a number of MPs and senators who were doctors to get the civil conscription subsection put into the legislation. You'll see it up there, so not as to authorise any form of civil conscription. This is a really crucial subclause to understand the Australian system. There have been 3 cases in front of the High Court of Australia to interpret this section, none of which are totally relevant, but I'm happy to talk about them in the question time. But the government's interpretation of this provision is as follows. Number 1, they cannot require doctors to work in a public hospital system. Number 2, they cannot prevent doctors from working in a private system and providing private healthcare services. And number 3, they cannot control extra billing. So doctors in Australia are permitted, under this interpretation of the Constitution, to extra bill. And those 3 provisions, those 3 interpretations of this constitutional provision are absolutely central to the way in which public and private finance has developed in Australia. So, moving back into history. After this constitutional change was put in place, the government, which was a left-leaning government, passed the Pharmaceutical Benefits Act again. Before it could get round to instituting public health care, it lost the election and was replaced by a right-leaning coalition government. The right-leaning coalition government was ideologically opposed to the concept of public health care. They believed very strongly in the primacy of markets. They believed very strongly that private providers should provide healthcare services even if a public system could do so more efficiently. So they were absolutely committed to the idea of preventing public healthcare in Australia. They remained in power from 1948 to 1973. In 1973, a left-leaning government was finally elected and tried to pass an act to establish a universal public health system in Australia. Note, tried. It took a double dissolution of both houses of Parliament and a new election for them to get the numbers to ram this through and get it into law. It was in law for a period of a couple of months when the Governor-General of Australia, very controversially, dismissed the left-leaning government and replaced it with the right-leaning coalition, despite the fact that the left-leaning government had the majority of seats. This was an enormous constitutional crisis. The right-leaning government's first act was to progressively dismantle the public healthcare system. It was not until 1983 that the left-leaning political party was re-elected to government. Its first act was to create a public healthcare system that was adapted from Canadian Medicare, and it too is called Medicare. And that was through the Health Insurance Act. It's important to note that the right-leaning coalition did not in any way stop opposing public health care. It went to each election subsequently promising to undo it, to repeal it, and to go back to purely private provision. By 1996, they had lost multiple elections, and they realised that they could not ever win another election by promising to repeal Medicare. So they pragmatically accepted that they could not repeal public health care. But they still maintained their ideological opposition and their absolute commitment to private provision. And it's really important to understand that context for what comes next. So let me describe the Australian system, which is quite different, although it was inspired by Medicare, inspired by Canadian Medicare, is quite different in a number of ways. The first issue is that the Commonwealth uses its power under Section 96 of the Constitution to make conditional grants to the states. And it uses this to partially fund hospital care. So the Commonwealth funds 40% and the states and territories fund the remaining 60%. It's a conditional grant, so that they sit down every 4 years and work out the terms and conditions under which the Commonwealth will transfer the money to the states and territories. There has been a movement and a change, and so the model is now activity-based funding. There has also been incentives put in place to encourage efficiencies in the way in which public hospitals do their business. And so there is now a financial incentive for efficient practice and efficient throughput of patients and efficient management of clinics. And this is quite a significant and important step. That 40% and that 60% that are funded respectively by the Commonwealth, etc., also include salaries, not just of nurses and allied health, but of doctors. All doctors who choose to work in the public health system in Australia are salaried. They are employees of the hospital and health service that they work for. Their remuneration is negotiated between the state and their union, so it's done at a state level. It is subject to usual labour law practices. They can take industrial action under certain circumstances, and they can, if they can't reach agreement, a body called Fair Work Australia, which deals with enterprise bargaining, and will intervene and make a determination about the terms and conditions. But that is a further key difference from the Australian system to the Canadian system. As salaried employees, they must follow the directions of their employer around issues like efficiency, management, queue management, clinic management, etc. Danielle yesterday in her presentation spoke of clinical autonomy being retained by Canadian doctors. Australian doctors have lost managerial autonomy, and their clinical autonomy is somewhat constrained by the policies and protocols and practices within their hospitals. They are embedded in a system and the concerns of a system in the way that Canadian doctors aren't. So they must balance the individual and the collective good. And that's also emphasised by their professional body, which has standards in relation to and guidance in relation to their role as stewards of a public health system. Through their enterprise bargaining, doctors are permitted dual practice, so that you can work in a public system and a private system. And that is a key component of the enterprise bargaining agreement, because the Constitution, as interpreted by the government, is really clear that dual practice is permitted and permissible. All right, then we have Medicare. Medicare is somewhat similar to the Canadian system in that it's a fee-for-service payment, so there's a schedule of services with a payment code attached. This can be claimed by all doctors who work in private practice, diagnostics, so pathology, radiology, nurse practitioners, midwives, etc. So that is the majority of Australian doctors work in the private practice and so can claim these rebates. There are two ways in which they can do it. They can bulk bill, or they can directly bill the patient, claim the Medicare reimbursement, and put an extra billing on top. There's no way to control the extra billing. That's entirely up to the discretion of the doctors, and so costs of healthcare are extremely variable depending on doctor, speciality, and so on. So that is, I should be clear that you cannot claim a Medicare rebate for public patients in public hospitals. You can claim it for private patients in public hospitals, and that's a valuable income stream for Australia's public hospitals. All right, so that is the system in a nutshell. Then we get back to this issue about commitment to private practice and to private health insurance. The right-leaning government, when it was re-elected in 1996, was really seriously alarmed at the decrease in private health insurance coverage. So it decided to incentivise people and penalise people to make sure they purchased private health insurance. There are three ways in which they did this. One is community risk rating, which means that you can't stratify the premium costs on the basis of age, gender, health status, etc. That really didn't work. Then they moved on to carrots. So they incentivised and provided subsidies for purchase of private health insurance, and that was stratified by age and stratified and also means tested. So once you received a certain level of income, you could no longer get the subsidy. That didn't work either. So then they moved to sticks, and they decided that if you do not hold private health insurance after the age of 31, or if you stop holding health insurance after the age of 31, yet they would sting you with an extra 1 to 1.5% in taxation penalties. So you have to pay that additional tax burden. There are some low-income people get that waived, but everybody else has to pay if they do not have private health insurance. And that didn't work either. People were still not interested in buying a product when they've got a good public health system and service. So then they moved on to the next stick, which is what is called lifetime health cover loading, which is if you don't take out your health insurance by age 31 or you drop it, then by law, health insurers must at least double, if not triple, your premiums for a 10-year period to penalise you for dropping private health insurance. All right, so this little graph shows some interesting. The first dive is the introduction of Medibank. Then you'll see that it increased once Medicare went, and then it dived again once Medicare came in. And you can see then it gradually tapered off. 1996 is the key point, which is where this private health insurance began to be introduced. The big spike at around about year 2000 is lifetime healthcare loading. So you'll see that the coverage in the population is at about 46% of Australians hold private health insurance that allows private hospital cover. The interesting piece also is the difference between the yellow and the red, and that's the type of policy that's held. The yellow one is comprehensive, and the red one is some services are not covered, so you might not get obstetrics, mental health, cataracts, and so on. And some are excess payments, so you might have to pay the first 1,000 or up to 10,000 as your maximum claiming. So there's a lot of potential there for you having to make substantial co-payments to actually be able to use your health insurance under that model. All right, so one thing to note is that the costs of that private health insurance regulatory system are $7 billion per year in direct subsidies, and that's increasing at a rate of about 7% per year. So there's a really significant question about the sustainability of the system. Macaulay argues that the assumption that higher rates of private hospital usage would relieve public hospitals, which underlay this private hospital subsidy, is flawed as it only considers demand-side factors. And this graph shows elasticity in the system, and the percentage change in proportion of doctors working in each sector corresponds to a 1% increase in earnings. So just one quick comment about wait times. Private health insurance just reassigns the wait times. So it's based now on your ability to purchase private health insurance as opposed to actually making any meaningful change. The real change in the Australian context is around, in terms of wait times in public health care, is in relation to increased efficiency in the system, in the public hospital system. Private hospital and private health insurance has made little to no difference based on the evidence in terms of wait times in the public system. Thank you, everyone. And I look forward to hearing everybody else's presentations.
Thank you.
Okay, let's put that up a bit. There we go. How's that? Good. And as we wait for the slides to come, good morning. It's lovely to be here. I'm very much enjoying being in Canada. I'm enjoying the Ottawa Spring. It's super. I'm enjoying Colleen's French, which is much better than mine. And it's lovely. And oh, there we go. We're on. So this is very much, although I'm here, this is a lot of the work I'm presenting is from our health systems grouping at the Centre for Health Policy and Management. So lots of other names are up there too. And I want to thank particularly the Irish Health Research Board, WHO, and the Irish government for various funding of different things that we've been doing, and also thank you so much to Colleen and colleagues for inviting me here. So I'm going to try and give you some potted highlights, a whistle-stop tour around the Irish healthcare system, and at the moment we are in a playing twister with private finance, if you like. So we've got ourselves entangled and we're trying to get ourselves disentangled, which is an interesting journey. So anyway, let me see if I can, does that go? There we go. Okay, so Ireland, where are we, who are we? With apologies to Jerry Rafferty, it makes me laugh though, so I will use this slide. So a small democratic republic, we have about just under 5 million people. We don't have universal health care. We've never had universal health care, and only about 5 years ago did we actually try and get universal health care for the first time. So there's no legal entitlement to health and social care. There's only eligibility for some things on the basis of means, or sometimes occasionally on need. We are largely tax funded, although that's been decreasing, and we behave very oddly for a largely tax-funded system. We have high supplementary private health insurance cover, around about 45%, though it has been higher, and that is entrenched into the system. And so we do now have an embedded two-tier system, and have had that for quite a long time. So that private insurance buys you faster access into the sometimes into the public system, and certainly into hospital care. And it is embedded through taxation subsidies from government, and also you are penalised if you are a late enroller. So if you're over 35, you are penalised for every year that you do not enrol if you then decide to come in. So now I'm 50, help. That would be a bit of an ouch if I now take out insurance, which I currently don't have. So anyway, that's a quick one. In terms of this graph, which is quite busy, it shows, however, the sort of solidarity funding levels in the blue for the EU 28. The EU average is shown in the orange. The green shows the Irish situation. So Ireland has lower solidarity funding than most other EU 28 countries, and certainly the high income ones. What we do have, however, is a does this have a pointer? No, it doesn't. Okay. So what's that? Apparently not. Anyway, we do have quite high supplementary health insurance cover, similar only to France and Slovenia. So we're hearing about France later, which will be interesting. However, the fundamental role of insurance in the Irish health system is not to cover co-pays, which the insurance doesn't cover that much, really. Certainly not for non-acute care, at least. Okay, next one. You can see the components of total health expenditure here from 2004 to 2013, and you can see here in the red the gradually declining public proportion in terms of taxation-based funding and the increase in private importance of private health expenditure, particularly the private health insurance, which people hung on to through the recessionary period, which was quite interesting. I thought recession might kill off some of the private health insurance cover. It came down a bit, but not that much, actually. So why are people buying private insurance in the Irish healthcare system? Well, this shows the summary of 3 different surveys taken by the Health Insurance Authority and some of the key variables and key aspects there. So first of all, the first point is the perceived inadequate nature of public services. Even though in some cases there's only public services because the private sector only do what's profitable, there's also issues of concern about the cost of treatment. If you need a high cost treatment in a private care centre, then you obviously want to make sure that you don't face catastrophic payments. But what's interesting is the final bar has been increasing quite substantially, and that shows fears of lack of access into public services, and that's a really critical thing here. And we can see here some quite horrendous waiting time, waiting list figures here for Ireland. I could show you similar data for outpatient appointments, but this is for number of adults waiting for inpatient and day case hospital treatment. And even before the crisis that we had in sort of 2008, 2009, waiting lists and waiting times were very high. But what we've seen now is that they've gone through the roof even after the recovery of the economy from austerity. So we can see here in the yellow shows the number of people who've been waiting over 12 months to get into an inpatient visit. And whilst we managed to squeeze that down, even in the middle of austerity, that's now shot up exponentially. So we have a huge problem. So private health insurance does not solve waiting list issues. Even now when we've had 3 expansionist budgets, public sector budgets after the austerity years, we are still struggling to cope with these waiting lists. So they're a real key problem for us. And then recently, last November, we had the public service broadcaster, RTE, produce an investigative journalism piece called Public versus Private, The Battle for Healthcare. There was a whole massive furore about this program. They were looking at the whole issue of dual practice consultants. Now, there has been a sort of rough guideline of 20%. You're allowed to do 20%. That was quietly ditched without really telling the public. And so what shall I say? A substantial minority of consultants are now substantially gaming the system. Not all the consultants and not in all the hospitals, but there's a substantial amount of, if you like, unethical dual practice going on. And one of the worst cases is shown here, where it says in one case a consultant observed for 8 weeks was working less than 13 hours. They should be working 40 hours. And what they did, particularly with some consultants who had long public waiting lists and were still breaching their hours in the public sector, they actually followed them. They followed them with cars and cameras and saw them, and they timed what they were doing, which is a lovely piece of investigative journalism. And the lady here on the right was one of those who'd been waiting for an incredibly long time on the public waiting list, and she was in tears when she said, I just had to go private because I couldn't wait anymore. So she sold her jewellery. So this caused a massive furore. The Taoiseach, the Prime Minister, the Minister of Health were saying, we have to take these consultants to task. We can't be possibly allowing this to happen anymore. So we'll see what happens. All talk and perhaps no trousers yet, but let's see where we go with that one. So how do we get here? Well, the recent history of private health insurance. Basically, private health insurance was established through a semi-state if you like, insurer back in 1957. By the 1990s, it was liberalised by the EU, who said you can't just have one insurer. You've got to open up the market. So by the 2000s, we had an oligopolistic market with about 3 or 4 insurers who actually just followed each other. They didn't really have price competition because the sort of semi-state insurer had all the high risks, had all the older people, and the sort of later entrant insurers didn't want those grannies. So it was like dump the granny competition. We with lots of cream skimming going on because there was no risk equalisation scheme. So there's no incentive really to not chase after the young and the healthy, because they're low cost. So there was a proposed risk equalisation scheme from 2005 that was then declared unconstitutional by court. So the private insurers came out and said, that's not constitutional. And the courts agreed eventually. They said the particular form of risk equalisation proposed was not constitutional, but you could have another risk equalisation scheme which could be constitutional. And so we then spent another 8 years getting that risk equalisation scheme in. It's not perfect, but it's better than it was, certainly. Then an interesting turnaround. The last government to this one decided that, well, if you can't beat them, join them. Let's have a universal private health insurance system. Let's just do it that way. Let's go Dutch. Let's do what the Dutch did, and everybody can have insurance. And then that tanked because the Dutch then started, running into problems of cost escalation, and it was all going to be very expensive, and it was always going to be very complicated, and the subsidies, and we were going to have to hire more civil servants to work out what we were doing, so that got shelved too. But to keep the insurers happy, because they'd suddenly lost the prospect of having a universal system, the government decided to introduce this lifetime community rating, which I was telling you about earlier, where there are now penalties for those enrolling who are 35 and over. So what that did, that lifetime community rating, and you can see it with the top blue line here, is that it gave it a small bounce around 2014, and that was in response to basically, if you don't get in now, you'll get penalised. So it kind of halted the slight decline that there had been during the recessionary period. But it's around sort of about 45% now. Okay, in terms of austerity, we had the mother of all economic shocks. Probably not quite as bad as some of the Baltics, but certainly longer. We had 6 austerity budgets. Economy collapsed. Unemployment went from 4% to 14% overnight. Our debt to GDP ratio now resembles that of many low-income countries, and we were horribly squeezed. On employment in the public sector shot down hugely. Hospitals were slightly better protected than community services, which were killed. And this lovely quote from a government policymaker, I don't think anyone's ever undertaken what we've undertaken. It's surprising that we've survived the experiment. And the way of surviving the experiment was the government did lots of cost shifting onto households. And so basically things that you would have been getting before, you're not getting anymore. It reduced the medical card cover. The medical card is the safety net, basically, for the poorest group. It brought in prescription charges and then brought them up them again and again. We had higher charges for hospital care and a higher threshold for drug reimbursement. Lots and lots of cost shifting onto households. And the consequence of this then was, in terms of sort of a heavy burden for some households, and we see here the chart showing private healthcare payments from 2009 to 2015-16, looking at household budget surveys and looking at the different kinds of things people were spending their money on. And what we can see here in the biggest chart in the blue is health insurance. So people were hanging on to their health insurance, but what that meant was that they were actually sacrificing spending on some of the other areas that they were having to pay more for. So we can see that they were hanging on to their health insurance, but they were decreasing. The green shows dental care. So people just weren't going to the dentist so much anymore. So they were sacrificing that. They were also sacrificing the GP care too. So the yellow, we can see people spending less, if you like, on the health care that they need today because they want to keep the private insurance for the fear of what might be coming down the road. So it's a horrible trade-off, but that was certainly seems to be the kind of thing that was going on there. So insurance cover, if you like, crowding out some of the genuine healthcare needs for today in terms of some of the user charges. So in 2016, there was a general election, a minority government. We have a minority government here. It's propped up by the opposition and a new minister for Simon Harris. And we had a Popeye moment where everyone said, "I can't stand it no more." You know, do you remember that bit from Popeye? I don't know if you remember that. Maybe it's my age. I can't stand it no more. So everyone said, right, you know, we've got this coalition government. We'll all get together and devise a 10-year strategy. So all-party parliamentary consensus. And they had a committee. It met for a year. We were privileged enough to be, I led the technical team that supported the parliamentarians in devising a 10-year plan to look at how do we get a universal system, because we've had this entrenched two-tier system and it's performing poorly. And then in May 2017, we produced this 10-year plan for health reform devised through political consensus, and it's called Sláinte Care, which means health care. And sláinte is what you say when you raise your glass to someone. So it's a very Irish thing, sláinte. And basically, this then had, this gave legal entitlements to quite a full basket of care. It's talking about having wait time guarantees. At the moment, we're looking at wait time guarantees for inpatient care of about 18 months, which isn't much of a guarantee. And so we're trying to pull that right down. And then we're eliminating or removing a lot of the co-pays. You can't get rid of everything because you can't afford to, but it's substantially bringing that down. A huge expansion in primary and community care. So reorientating the role of the hospital and investment into thinking about more workforce, expanded workforce and integrated care workforce. Funding a bolstered beverage system with possibly some ring fencing through some kind of insurance thing. So a transition fund to allow catch up, and then taking private care out of public hospitals. Okay, so that gives us some big challenges, disentangling private from public. If we're going to do this, it requires removing the fee-for-service for doctors for private activity in public hospitals. That's got to go. It requires removing private insurance payment to public hospitals. That's got to go. It requires bringing down the waiting times, some of the longest in Europe. It requires reworking the role of the hospital. It's a whole system transformation required to make this thing work. Otherwise, there's still going to be the incentives to have the dual practice and for people to try and pay their way through the system. Perhaps most importantly, we have to shift public perceptions. There's a lot of fear out there. Fear about the quality, fear about access, fear about cost. And changing that default perception from public bad, private good to something different, you're going to have wins on the way. So the Sláinte Care is designed to provide some quick wins in terms of removal of key fees, thank you, and things like that, which will gain some support. So it reminds me very much of this quote, "Grief walks upon the heels of pleasure, married in haste, we repent at leisure." And Ireland has certainly had that. And I know Canada is not marrying in haste. Your court cases are running for quite a while, but you will have to repent at leisure depending on what action you take. So there's a lot of political dynamite points for us. We have to change contracts for consultants. We have to create accountability and authority in the system, which we do not have, which is a key for getting waiting lists down. Replace private funding, take on the vested interests. It's quite a biggie. So last slide, if I can get to it. I'm pressing the button, and there we go. Okay, I didn't know whether this. I chose this because I thought this might be a Canadian kind of thing. But you have to have your teeth in florist fryers. But the basic point is prevention is better than cure. If you're going to let the genie out of the bottle, Ireland shows you it's a hard road to get the genie back in the bottle. It's a hard road to put out the fire. So you need to be quite careful what you do. Thank you very much.
Thank you very much, Steve. And Zeynep?
to my level. Thanks. How this is. Excellent. So when I'm waiting for the slides to go up, hopefully they are fine. Okay, great. It's so nice to be here. Thank you to Colleen to organizing this very exciting event and inviting me. So my mission here in the next 18 minutes to talk to you about French healthcare system, which will be quite a cultural shock, I think, from after Ireland and even Australia, because as you may all know, France has a Bismarckian model, which is a social insurance model, and we have universal coverage, effective universal coverage. But the first thing I think you need to know about French healthcare system, which is quite important, it's structured about 3 values or principle. It's not really liberté, égalité, fraternité, but almost it is liberté, solidarité, and pluralism. So these are actually not simple slogans or like empty words. When you talk about solidarity, solidarity is the fact that the belief that healthcare should be consumed by need, not the ability to pay. So this is a very well-shared notion by all, and since from its beginning. So this is really important. Interestingly enough, all parts of the population, from right to left, share this value. This is like shown in opinion polls, etc. And interestingly, in the presidential elections, from Le Pen to the left, extreme left, Mélenchon, they were almost all saying the same thing, increasing the healthcare access in different ways. And when Monsieur Fillon proposed to question the role of public insurance against private insurance, he tumbled down on the opinion polls, and before even he pulled down because of corruption charges, but he was actually quite unpopular. So this is important to note, but at the same time, and it's one of the French paradox maybe, there's French medicine is medicine libérale. Thanks. I wouldn't. Thank you. Is it better? Is it okay? At the same time, this medicine libérale, all of the healthcare providers are private, and we believe in the liberty of installation. There is no rules restricting them, and liberty of medical practice, and there's choice both for patients and for healthcare providers. That's why anytime you want to do a reform, trying to restrict any of these things, that the medicines are in the street, striking and yelling, and they're quite strong on that thing. And there's pluralism. There's a multitude of providers, and as you will see, actually, in healthcare insurance provision as well, there's a multitude of providers. So when you look at the healthcare provision, ambulatory care is mostly provided by private fee-for-servicely paid providers, including nurses, any type of profession you can think. And in the hospital sector, private clinics play an important role. Almost like 50% of all surgery is provided by private hospitals. When you look at the elective surgery, the numbers can go to the 80-90% for cataract, for example, clearly. But there is regulation, like they are, in terms of the prices are regulated in all sectors, including the pharmaceutical sectors, very strictly. In the ambulatory care sector, there are national negotiations between health insurance fund and the representative of the healthcare providers. So this is collective bargaining, and the prices are set at the national level, and healthcare professionals respect that. In the hospital sector, we use DRG-based payments since 2005, but there is a both price and volume control for ambulatory, for the private and public hospitals with 2 different budgets. It's a macro level price volume regulation with separate budgets for private and public hospitals. So it is very strictly followed up what is provided. There's an efficiency incentives in the same way for public and private hospitals, etc. But at the same time, overbilling is allowed. because otherwise it will be too simple. You may have all heard about in the ambulatory sector, Sector 2. The little story behind the Sector 2 is that because healthcare professionals, they have collective bargaining, they accept to respect a national fee. In return, they see that some of their social and retirement contributions paid by the social insurance fund. In 1980s, I think because there was deficits, etc., in the healthcare professional asking for it, overbilling, health insurance fund said it's fine. Okay, if you want to overbill, we create a Sector 2. You go to Sector 2, but then we don't pay for your insurance, for your social contributions. They thought it might be, because also you should remember that in France we have lots of doctors. There are 50% more per capita doctors than in Canada. So it's not like there's a limited number of doctors. So except when they opened the Sector 2, the demand from healthcare professionals for overbilling was so strong, everybody wanted to be in the Sector 2, so Social Insurance Fund realized that it's not going to work. They quickly closed the doors to Sector 2. Today it exists, but there is quite a restrictive way of going into Sector 2. There are rules, etc. It's about, it is experience, lots of other things. So today, I think about 50% of all specialists are in Sector 2, and for generalists, I'll say about 20%. So when you think how all of these are financed, there is a well-established and assumed two-tier health insurance model. The first part of the model is a compulsory public health insurance, topped up by a private insurance owned by 95% of the population. So when you look at the first tier, social health insurance, this is obligatory. This is one place where there's no choice. Insurance based on your employment status, either you're a wage owner, independent, or agriculture, you are affiliated to a regime, and then you pay your contribution. And we also have three big schemes, basically CNAM, health insurance for wage earners, agriculture, and the independents. They cover like almost more than 90% of the population. And we also have since 2000, this is how the insurance became universal, state-funded insurance for the poorer part of the population. And unemployment are already also covered, and so everybody is covered. And this first tier, social insurance, pay for a very generous health basket. This health basket covers medication, home care, and pharmaceuticals, of course, mental health care. It is quite generous because we did European comparison, so the number of things covered is quite large. And it is harmonized. It wasn't automatically, it took about 40, 50 years to harmonize, but today, independent of which regime you are affiliated, you get the same benefits. But there is cost sharing for everything, including for primary care, generalists, etc. So it's about, for ambulatory care visit, you pay 30% out of pocket. For hospital, it's about 20%. For medication, it varies depending on the effectiveness of the drugs. It could be from 30 to 65%. That's why, because of this cost sharing, we have the second tier, which is a complementary private insurance. What I would like to underline here, what we have in France is a complementary insurance, which is different from Canada, where you have supplementary insurance to cover things which are not covered, or in Ireland to cover populations which are not covered. We actually, everybody is covered, so the role of private insurance is to cover exactly the same services, but to reduce out-of-pocket payments. This is provided by a mixture of different insurance organizations. They are not all for profit. Actually, half of the market is by mutuelle. You may have heard about it. These are non-profit organizations owned by their own insureds. And you have non-profit institutions, and you have for-profit organizations. So when you look at what does it give in terms of funding, you see that it's about 75% of the healthcare expenditure is funded publicly. Private insurance plays quite a high role. This is actually like the third highest in the OECD area. It's almost 13.5%. But I actually checked, Canada is not that far from that. It's, I think, 13% in Canada. But when you look at the out-of-pocket payment, it is one of the lowest in the OECD area. And when you look at the international comparisons, and this is another version of what Stephen already showed you, but these charts give you what does it represent, public and private expenditure in terms of GDP in your economy, the share in the GDP. Actually, to my surprise, I'm not sure if you see the numbers there well. You have to trust me on that, or you can check on OECD site. France spends about 2.3% of its GDP privately, against in Canada 3.1%. Actually, Canada spends more privately than France, which represents $14,000 adjusted for purchasing power in Canada against $950 in France. So, but when you look at the public part, France is higher. It's about 8.7%, and in Canada, 7.4%. So you may ask how this is possible with this big health benefit basket, everybody's covered privately, etc. The answer is in the mechanism behind in the system. There are two basic mechanisms. The first one is what we call chronic costly patients disease scheme, which is called ILD. This is actually installed from right beginning of the system. It's in 1945 when the system set up with cost sharing in the model. Clearly, the question was, but for very sick patients, this out-of-pocket payment could be quite important. So that is why this scheme, from right beginning, installed. So there's about a list of 33, 34 conditions, which includes clearly things like cancer, stroke, etc., but also diabetes, high blood pressure, mental health. For this condition, if your doctor says that you have one of these conditions, cost sharing is waived. So there's no cost sharing for these healthcare consumption linked with this condition. But you can have an ILD on, let's say, diabetes, so anything linked to diabetes will be free of cost sharing, but it doesn't mean that if you have a hip replacement, you won't pay anything for your cost sharing hip replacement. So that is why the second scheme, which was introduced in 2000, gives free complementary insurance for the poorest part of the population, because ILD scheme is not mean tested. It's only a solidarity on the basis of health status. The second scheme is mean tested. It is for the poorest part of the population. They actually benefit from a health care insurance scheme that they don't pay any cost at all. So they basically don't pay anything. But even that doesn't really help. I mean, it did help a lot. There are studies showing that this was actually one of the best things that French system did to improve the equality and access. But we still could observe that there's a problem. People who were just not poor enough to be in the CMU scheme, universal coverage, they're just above the limit. They are like the poor, not poor, but middle poor. So for this, the solution the government, several governments have, is to give subsidies so these people who are not poor enough to be in the same, but a bit above, give subsidies so that they can buy private complementary insurance with limited effectiveness, I would say, because those without controlling the content of the insurance packets. I'm going to quickly talk about it. For the system works, there are several regulatory mechanisms. I already talked about price regulations, but there's also laws or regulations about overbilling. At the beginning, when the Sector 2 created, they said that doctors can overbill, but it has to be with tact et mesure, we say in French. I guess like within reasons, but what is within reasons? What is within reason for me may be different from you. So nowadays, actually, this tact et mesure became more concrete, and health insurance fund actually trying to limit, saying that not more than 130% of the regulated price and things like that. And insurance market is also regulated. I forgot to say, but in the market, they have collective voluntary insurance packages offered through workplace, often, like you have private insurance here, but it is for complementary insurance, so they're collective packages, or you can buy your private insurance individually. In the collective packages, selection is not allowed by law. They can't select patients, etc. They can't put the prim to risk adjust the prims. But in individual contracts, there are tax reductions for insurance companies who do not do health risk selection. So they can't really give health questionnaire, for example. But age is used for risk adjustment, and it is fine by the law. So there is still risk selection, but limited, let's say. Come back to that. So when you look at the issues, I wouldn't say that the system works quite well, but there are still issues because fundamentally private insurance market is unequal. It's normal insurances, they wanted to choose their patients in terms of low risk, etc. So while dumping and selection as it is not allowed, they still can adjust the prims so that it will be unequal. Just to give you very quickly, and as I said, because there is an age adjustment, as you get older, your prim will go up, which happens. And when you are retired, you lose your workplace insurance. So clearly, after 65, there is an issue. So this is private health expenditure. The pointer doesn't work. I think I'll retry, but no, it doesn't work. So I'll try to work through to this. The dark blue is out-of-pocket payment, and the light blue is the insurance premium paid. And the quarters are, this is the retired population. Q1 is the 20% poorest part of the low-income population, and Q5 is the 20% highest income. And you could see that there's a bit redistribution because richer people pay more, but the little yellow dot, which is taux d'effort, taux d'effort is basically how much what you pay for health insurance privately represent in your income. You could see that the lowest income groups, this represent quite high compared to the highest income groups for retired. In generally, this is the same thing, but by general population by age, you could see that the premiums goes up by age, and the taux d'effort goes up by age as well. So these are the issues noted by the Health Insurance Fund as well. So this is a new trend, but more and more what's happened, what we're talking about is regulating the insurance market as well to have responsible contract, because apart from the inequality of the insurance market, another issue that we noted is inefficiency, because in the areas where regulation is less, which is optical care, dental care, which is very badly paid by the social health insurance, there actually, because of a dynamic insurance market, prices went up so much. So depending on the income groups, you could actually come at one point, you could have 1,000, 2,000 euros for your glasses a year endlessly. So this is actually inflationary beyond for the health insurance market. The prices goes up, so it is bad for everybody. So health insurance fund actually introduced what's called responsible contract, asking health insurance not to pay above a certain things, and there is tax reduction for responsible contracts. So actually, the health insurers have advantage to be responsible contractors. within limits. So just to finish, because I've largely passed, I think my messages are clear. It's just, I think the privately provided healthcare can support public health system, because private provider doesn't mean private payment. It is two different issues. In terms of private payment is, I think the question we need to ask, how much the funds raised privately can contribute to improve public health system, because it is resources for all at the end. But as the question, always the answer, the details, and the devil is in the detail. The regulation is important, and there will be side effects that you need to carefully look through. What are the effects, and carefully think about how we can regulate. I'm not saying only by law, but economically as well, as what we do in France. Thank you.
Certainly like to thank the three panelists and for their presentations. One, to give us really a very broad brush understanding of the systems and how those systems were formed and where they're at and what the issues that they're dealing with. And also really to give us some insight that as we here in Canada are starting to really have to give very serious consideration to the possibility of how and what are we going to look to into the future as some possible solutions of ways of making the changes depending upon the court decisions that are going to be happening here in Canada. So lessons learned from other jurisdictions. What I'd like to do is to open it up to individuals in the audience to pose questions. And there are microphones. There's one microphone. Do we have, how many microphones do we have? One microphone. So queue up. Could be an example of the future to some extent. But Colleen.
Thank you very much. It's such a fascinating set of presentations. My question is for you, Zeynep. Just so that I understand this, I think I understand this, but I just want to be clear that the French government subsidizes the purchase of private health insurance for the poor to cover the copay that the French government puts in place. Am I right about that?
Yes, you're right about that.
Okay, that's good. Thank you.
That's actually has been for a couple of years now. That was one of the issues. Some of the economists, us, pointing that paying the poor. This is the dilemma of the French healthcare system in a sense, because the system to be equal. Now we realize that everybody has to have complementary insurance. So this is an objective for the government. What I didn't even say, actually, since 2000 and end of last year, all of the small place private provider, even if they have a very small number of employees, they have to provide a collective contract to their employees, because before most of the enterprises they did, but not everybody. So now it's called the INE law. It's by law, everybody has to provide, all of the employers, they have to provide a private insurance to their employers. The reason for that, because we know that collective contracts are more generous and better than individual level contracts. So they wanted to improve the share of population having collective contract. But some say that this is not a solution. Now I think the solution they are going through is to regulate the market better, so they have a minimum guarantees. It's more visible. It's like in the United States, but in the private market, you don't know what you're getting with your insurance. So they're trying to increase the readability of the system, saying that there are different levels, and this should be the minimum level, etc., etc.
Just to follow up to that, because I find it fascinating that you've gone down this road, and it's not that long ago, it seems. Was there never a discussion about creating a public complementary care system? So you weren't actually, I mean, I guess the market would say, why would the public want to compete with the private? And the private would say, yes, you can't compete with us. But it is an efficiency question. So, you know, the public option wasn't there for Obamacare, specifically because the private insurers wanted to keep it out. Was there that kind of discussion in France around, because it seems somewhat of an absurdity to have public dollars essentially fund a private system. So any thoughts on that?
There is a discussion about that, actually. There's a lot of discussion about that. But, you know, in a sense, for the poorest part of the population, CMU, this is typically public complementary insurance for the poor part of the population. So they actually do that. And these people benefiting from the public complementary insurance is like NHS, or it's in Canada. You don't pay anything when you go to the doctors. But I guess the private complementary insurance market is big. I actually looked at the numbers to prepare the presentation. It's actually very profitable and big market. So it will be quite difficult to abolish this market. You know, just I think realistically, you have to do with what you have in hand. And, you know, like I think it is easier to regulate the market than abolish it completely. So it will be very difficult.
Hi. Thank you for your presentations. I'm going to do my question in English, but I could have done it in French, but I'll do it in English. So my question is for Mrs. Or. I wonder if you have any numbers about physician revenues in France. I heard that some years ago it was really lower than in here. So I wonder if it makes a difference about the privately provided services, if there is a difference. My question is about basically revenues.
Yeah, globally, in international comparison, French doctors earn much less than, I mean, American doctors are here, French doctors are here, but it is in the lower side of the spectrum in OECD countries. It's not the lowest, clearly. But things are changing a little bit, like especially for generalists, not because of the negotiations, but more and more there's value-based payment approach as everywhere else, trying to find new ways of paying. So the strategy of the health insurance fund has been, I'm not going to increase the fees a lot with the collective bargaining, but if you're doing well things, high quality care is basically like the P4P schemes, so you can actually increase your income. Actually, the latest numbers for generalist income is pretty good. You know, they actually can increase their revenues by respecting this clinical recommendations that they never wanted to respect, and, you know, increasing vaccinations and etc.
I just had a question for Australia and Ireland about sort of this problem you describe of putting the genie back in the bottle. You mentioned that this sort of incentive system where if you enroll for private insurance at age 30, then you kind of avoid these rising costs. And so presumably there are people out there who just took that risk and now have gone decades without buying private insurance, and now they're trying to roll up this system so they kind of get a windfall in the sense that they've foregone these high premiums all this time. And then you've got other people who've been sort of squirreling away money into private insurance and who presumably will resent a change to a system that just levels the playing field. Is that affecting the politics of sort of putting the genie back in the bottle, or any thoughts on that?
Yeah, I think obviously people would be quite concerned if they've been paying for private health insurance for years and years and years. Now suddenly it doesn't confer to them an advantage, and I think that's one of the problems. Once you go down that route, you undermine solidarity. You undermine the concept of we're all in it together. And if you haven't been all in it together for a long time, what's the incentive for coming back in? So I think that the point is that you can't just focus on the insurance aspect. You have to focus on the entitlements aspect, which is where this long-term care plan looks at. So it's a much broader package of services, much broader package of primary and community care that appeals to the middle class who haven't had that. I mean, as a fairly well-off person living in Ireland, I've got to pay €50 to go and see my GP. Every time I go, we're recommending that gets completely abolished. We're recommending hospital entry fees get abolished. We're broadening out the primary and community care package, and we're going to be bringing down waiting time. So I think when you see it in the context of that larger entitlement, then people may well be willing to put down that private insurance. And one of the debates that we had with the parliamentary committee was, should we take away the tax subsidies to private insurance? And there's quite a lot of debate about that. And people said in the end, well, if the public sector is good enough, people will put down the private insurance anyway. So the problem will take care of it itself, and then people will be voting with their feet, which is the point. But you've got to have a viable and effective and quality public system for this to work.
And in the Australian context, there's a great deal of disenchantment, I suppose, with the private insurance at the moment, because, as you saw from the slide, there's an increasing sort of purchase of what we call junk policies. So people are purchasing private health insurance more for tax avoidance than they are for, this is a product I actually want, because the satisfaction with the public system is high. And unfortunately, when you buy a product for tax avoidance and then you come to use it and you can't use it, so there's a significant level of frustration there amongst policyholders about that piece of it. And I suppose the other point to make is that the narrative around why Australians should buy public health insurance has been a really interesting one. The government has positioned it to suggest that there's a moral imperative on the middle class to buy private health insurance to save the poor. So essentially this concept is that if you're middle class, you should be able to afford to buy this product to get yourself out of the public system and serve your social duty to the poor. And that narrative has actually been accepted by quite significant numbers of the middle class, and so that's not necessarily going to be affected in that kind of way, because they buy into this concept that they're doing a public good by stepping out of the public system.
Good morning. This question is very much based on the last few that have come up, which is actually one of the themes across all of the presentations this morning was the ways in which the public sector subsidizes private insurance. And to me, it's quite striking that this plays, potentially it even holds up the private market in a lot of jurisdictions. We do it here in Canada. It costs us billions of dollars a year. The US does it. It costs them tens of billions of dollars a year. At least in France, it's targeted, yes. Right? Here, it's actually larger the wealthier you are, which is completely contrary to what you might expect to have happen. So I'm wondering whether or not, and you know, I recognize that this debate is happening in some countries, but of course, every dollar that goes to subsidizing private insurance, there's an opportunity cost of that dollar. It could be going through the public system. It could be going elsewhere. Yeah. Right? How much is this an additional tool that should be used to control what happens in private insurance, that at the very least we should have them make a go of it on their own 2 feet, in the sense that this should not be publicly subsidized. And along with all the other regulations that we might be thinking about, this one, which has enormous public cost and is usually quite regressive, has been overlooked more or less in so many jurisdictions.
Comments? Fiona?
Absolutely. I mean, it's really interesting when you look at the Australian system, that you've got this really robust regulatory framework to encourage people to purchase it, but it's very much aimed at the middle class. So so they get benefits in terms of subsidisation, etc., that people who can't afford private health insurance don't get. And so to me that raises some really significant moral and ethical questions about whether it's justified and whether it would be best to shift. I mean, why is government trying to encourage people to buy a private product that they otherwise wouldn't buy because they don't think that they need it? When they don't, and particularly when it's a free market government, why are they subsidising a failing industry? Wouldn't that money be better spent elsewhere, either directly funding the public system, or if you want to maintain a private system, directly funding the private hospitals through directing patients from public to private directly and avoiding the insurance companies taking their massive cut off the top. It's an enormously profitable business. And one interesting other thing from the Australian context is when this regulatory framework was drawn up, guess who owned the largest private health insurance company? Government. So they put this regulatory framework in place to encourage people to buy a product that they sold, and that ultimately they sold that company for a couple of $1 billion downstream.
I would,
Steve?
yeah, certainly endorse some of the comments there made that Fiona's made. I think there's definitely a Sheriff of Nottingham flavour to this, you know. I mean, actually, to be honest, some of the more right-wing governments have actually tried to squeeze some of the subsidy. There was, the insurers were underpaying the hospitals for the care given. They were paying it at a standard rate, which wasn't reflective of full costs. And so that has been changed. There's now been a cap, was introduced by a right-wing Minister of Finance and was held to pay for introducing that cap in terms of the subsidy that was there. I think it's often an ideological thing. I think the words death spiral put the fear of God into many people, and they want to make sure that the insurance industry doesn't tank, which it could have done through the austerity period had, you know, and people were getting a little bit worried, and that when they introduced lifetime community rating was definitely to bolster numbers there. So government is very conscious of keeping this alive politically.
Working? Okay. In France, it's actually interesting because this INE, obligatory workplace complementary insurance, is introduced by the Holland government, which is a left-wing government, the last government, as an answer to increase the equity in healthcare system. So this was the idea of the left-wing government saying that, okay, one source of inequality is the inequalities in the complementary and insurance, so we're just gonna push it up. Everybody will. This is interesting. There was no discussion. So to the question, clearly we want to make sure that the money spent on private health insurance couldn't be spent somewhere else. That could have been the easier thing. Could be push up the limit for the CMU, poverty limit, so you cover more people with CMU in a sense, but we didn't do all of these calculations. So it's actually interesting. It wasn't to promote private, but in a left-wing government saying that we're going to push up private insurance to the name of equity. So it's paradox.
Yes.
Just sorry, just a quick follow-up. I just checked rapidly. I'm not exactly sure of the numbers, but for a physician in France, it's $120,000 a year salary, and the average in Quebec is $350. And this is for all, and for the specialists, it's $450 in Quebec. So there's a slight difference.
Yeah, Canada is close to US. Your influence.
Carolyn Toohey from the University of Toronto.
Carolyn, can you just speak right in so we can hear you? Thank you.
I'm Carolyn Toohey from the University of Toronto. That's coming through. Okay. Thank you very much. Really very interesting panel. And it has caused me to further reflect on some thoughts that I've had in the past about whether in wanting to emphasize the public sector and public spending as our route to equity, whether we risk having the excellent be the enemy of the good. And it seems to me that in each of the countries we've heard about today, there is a recognition of the role of private insurance and a regulation to various degrees of private insurance, as opposed to simply considering private insurance as illegitimate and letting it kind of develop on its own. I worry that we risk the latter approach in Canada, just treating private insurance as a sort of Wild West. And I think we'll be hearing more about this afternoon. So I'm wondering what the basis of how widespread is the legitimization of private insurance in the political system in each of your countries? Is it still a really partisan issue, or is there a broad public consensus? I think it varies across 3 countries from what I've heard. Is there a broad public consensus that yes, private insurance can play a role, but it needs to be regulated in the interest of public objectives?
Panelists?
In the Australian context, there's no real appetite to curb the private insurance market. It's considered sort of fundamental, I suppose, to the creation of and to the design of the Australian health system. What they're doing is really tinkering around the edges, and they're committed to sort of regulating more and more thoroughly. But it is very much broadly accepted as this is a legitimate part of the health system.
Steve?
Yeah. I think Mary Harney, who's a Minister of Health in the noughties, said of Ireland that she sails closer to Boston than Berlin. So the importance of private insurance in the psyche for many people in Ireland can't be underestimated. I think with coverage around 40, 45, 50%, that's quite a big political bloc. And any right-wing or centrist to right-wing party has to take that, or has taken that into account. And as most of the parties tend to be centre-right in Ireland anyway, it is the tail that wags the dogs. Or it has been. So I think the latest proposal to focus on a Beverage Plus system is quite radical for Ireland, and to get cross-party agreement on that, I think could only have come off the back of the total failure of the Irish healthcare system to deliver universal care and in a timely manner. So I think it's needs must. We have a window of opportunity to make huge change, and hopefully that will occur rather than going back to how things were. But things have just got so bad. So I think the political landscape has fundamentally changed, and now is the time for change. So yeah.
I think in France there's a quite agreement on the fact that voluntary health insurance reduced out-of-pocket payment, as you can see the numbers. And I don't think anybody imagined a system without any cost sharing. It is unsustainable. But there is an ongoing discussion about, what should be covered publicly or more publicly than privately. It's actually interesting. The Macron's in the presidential program, one of the things he promised, I'm not sure if he will be able to do that, to increase the coverage for dental and optic care, which are the 2 items least covered by the social insurance and where the private insurance play the most role. He promised that, so now there are like a bunch of people trying to see how it is possible. But I think one of the options coming out is that it might be more feasible or economical to regulate the complementary insurance market on how they deal with the reimbursement and what they propose in terms of coverage, because clearly insurance packages varies as well, but you can regulate that. This was my point about looking into the content of the packages and just giving a bit more transparency.
Yes?
My name is Colleen Busby. I'm with the Institute for Research in Public Policy, and I have a question mainly for Professor McDonald, but also for Professor Thomas. One of the challenges widely documented in the UK when physicians can practice both in the public and private system is a very sort of undesirable aspect of the private option, which is the practice known as moonlighting, which is the ability to steer patients into the private system when you could otherwise see them in the public one. How much, and I know Professor Thomas is going to probably talk about the regulatory structure for this later today, but Professor McDonald, since you're on stage right now, I did want to ask you about the extent that's an issue in Australia, and what sort of regulatory protocols are in place to deal with that issue.
Absolutely. I mean, it's a significant issue. That we call it cream skimming. So a Melbourne Institute paper has found that the incident of private hospitals transferring patients to public hospitals increases with disease severity and treatment complexity. So the private hospitals are just basically ditching the hard patients and chucking them into the public system. And it's also working the other way. So what we're seeing also is that doctors working in the public system are seeing a nice, easy, simple patient, if you like, with basic surgical needs, and are pushing that person into the private system. So it's definitely happening. I had an experience myself where I was in a hospital at A&E, and basically they would have admitted me if I had private health insurance, but as I don't, there's the door. Don't let them knock you on the way out. So there's certainly very much that issue. The other issue that has been regulated is basically corruption. So there was a great deal, particularly amongst diagnostics, there were inducements being offered to doctors, particularly, to push their patients to particular diagnostic companies, and kickbacks were being offered. And that's been directly regulated to try and prevent that from occurring. But the actual cream skimming piece hasn't really been dealt with. But it certainly does happen, and it has a really significant impact on public hospitals having to deal with these far more complex patients.
Thank you. We'll take one more question and then end the discussion. Yes.
Sarah LaBelle, Chair of the Ontario Public Service Employees Union Hospital Professionals Division. We represent 25,000 hospital professionals across the province, the allied health professions. So we have done a lot of research, obviously, on two-tier healthcare and the transition towards that, and the more recent movement towards more private healthcare, especially in Ontario. But it seems to me like we've come to the foregone conclusion that two-tiered healthcare is the inevitable end result, instead of maybe perhaps looking at how we actually republicize what has been privatized, what we are paying it for private insurance on. We have panelists here who are coming from all coming from countries where there is already a private and a public insurance provider. And if we look to the States, where it is entirely delivered in the private sector, what they are paying on healthcare is significantly more than what everybody else is paying that has a combination of public-private. And in fact, in nations where they do a single payer, and the most efficient economies in providing healthcare are actually economies that have decided that they're going to invest in a single payer or a dominant payer. So they've actually got more of a public system, i.e. pharmaceuticals and dental care and glasses and everything else. So should we actually be looking more at how we contain costs and how we do better by actually looking at more public delivery and getting rid of the private sector and the private insurance? Because at the end of the day, they exist solely to make profits, right? Not to actually deliver a service. They're there to make a profit. So if we actually pushed more for a public healthcare system versus a two-tier system, maybe we would all be better off in going that route.
Thank you. I think that certainly we'd all agree. I think the issue that we're in right now is because of this court challenge. We need to at least start to have the discussion and explore. But I think certainly within Canada, the universal system, and over the years looking at how to enhance the coverage to Canadians with our publicly funded healthcare system has been that objective. And that's what we are trying to maintain and enhance in light of what's presently in our face. So that's the issue that we're trying to look at and understand at this point in time, but points well taken. All right, I would like to thank the three panelists for very informative and insightful presentations and really very candid response to questions. So thank you.